The next talk will be on evidence-based management of severe community-acquired pneumonia. It will be given by CHACKO sir. He again needs no introduction. He's working as a senior consultant at Narayana Health City, Bengaluru. And his areas of interest are ultrasonography and echocardiography, ventilation in refractory hypoxemia, renal replacement therapy, and evidence-based critical care. Over to you, sir.
And he also writes interesting blogs.
Good morning, everyone. So, we will briefly consider what is the current evidence regarding the management of severe community-acquired pneumonia during the course of this talk. Needless to say, it's most important, one of the cornerstones of the management of severe community-acquired pneumonia is the early diagnosis, identification of the sickest of patients, treat them appropriately in an appropriate location, be it at the hospital or in the ICU, and also to make sure that they get the most appropriate treatment in terms of the best evidence available. And very important to realize that in severe community-acquired pneumonia, nearly 23% of patients get admitted to the ICU, 24% get intubated, and you end up using non-invasive ventilation in 20%. So that's a fairly high number of patients who need various levels of respiratory support in community-acquired pneumonia. And the mortality is a fairly high 26 to 50%. Not only is the mortality high, even among survivors, there is considerable disability, there is a high incidence of cardiovascular morbidity, respiratory illnesses in the future, and they also suffer significant disability as time goes on. Now, how do you define severe community-acquired pneumonia? How do you know that your patient has indeed severe pneumonia or not? There are two obvious criteria. Any requirement for invasive ventilator support means it is severe. There is no question about that. Septic shock with the need for vasopressors is again, needless to say, indicative of severe community-acquired pneumonia. These are from the IDSA ATS guidelines. And they also come up with 9 minor criteria. 3 or more of these criteria would also suggest that your patient has severe community-acquired pneumonia and he needs to be specially cared for. Typically, many of our patients present with fever, cough, very typical symptoms. But these symptoms are often masked, particularly in the elderly, who are more prone to getting pneumonia anyway. And imaging-wise, you would normally go by the chest radiograph. There may be typical changes, but occasionally you may not find those typical changes. You may be misled and you may need a CT scan. As we heard, particularly during the COVID pandemic, everybody who stepped through the door was getting CT. And of course, times have changed. CTs being so commonly available, we do not hesitate if we have a doubt in our minds regarding the diagnosis or the severity of the pneumonia. One of the most important steps, one of the most important advances in recent years has been the ready availability of rapid diagnosis through multiplex PCR. It has several obvious advantages, including rapid diagnosis. If you ask for a culture, we all know we need to wait for a couple of days, and that may be too late. So you get fairly rapid answers within the first few hours. It's got very high sensitivity, particularly in patients who've already been treated with antibiotics, patients who are referred to you from elsewhere, who have already been on antibiotics. So these are patients in whom cultures yield very low positivity, and you get a fairly high yield with the use of multiplex PCR. Viral pneumonias are increasingly being diagnosed because of this technique. Multiplex PCR, there are so many patients. Currently in our unit, there are about 3 or 4 viral pneumonias, H1N1, influenza pneumonias, who have severe ARDS and who could be diagnosed early purely because of multiplex PCR. And of course, it's got a good negative predictive value. If it comes negative, there is a fairly good chance that it may not be an infective cause. And studies over the years have shown good concordance with the conventional techniques, including cultures. So we have reasonable evidence to suggest that the correlation between cultures and the multiplex PCR is reasonably strong. So that's the way to go in the future as well, with the rapid availability of multiplex PCR. The most common pathogen is obviously still Streptococcus pneumoniae. And then of course you have non-core community-acquired pneumonia pathogens, which include Pseudomonas, other gram-negative bacteria, MRSA, and atypical organisms such as Legionella. Viruses, as I mentioned, are being increasingly diagnosed with the help of multiplex PCR. And influenza A virus is the most common. Most important, remember, is the PES group of organisms. Pseudomonas aeruginosa, extended spectrum beta-lactamase enterobacteriaceae, and MRSA, which require special attention and special treatment. Who are these patients who are prone to getting PES organisms, which includes Pseudomonas aeruginosa, as well as ESBL gram-negative organisms? These patients may have been previously on antibiotics, more days in hospital, on dialysis, poor immune status, residing in a nursing home. These are risk factors for PES organisms. Now the important question as to whether we should go by biomarkers. The commonly used biomarkers we have at hand are CRP and procalcitonin. Should we go by them? What does the evidence suggest? There have been plenty of studies, including the recent ProPria study, which have looked at this particular question. And procalcitonin seems to be much more efficacious in the diagnosis as well as in managing your patients with community-acquired pneumonia compared to CRP. And this particular meta-analysis is very often cited. Petter et al., in fact, they showed improved survival when procalcitonin was used to guide antibiotic treatment, particularly in terms of deciding on the duration of therapy. So, if you have severe community-acquired pneumonia in ICU, what treatment do you start with? What is the empirical treatment in patients in whom you do not suspect PES or Pseudomonas, multi-drug resistant bacteria, Staphylococcus, MRSA, and so on? So the routine treatment obviously is to use an anti-pseudomonal beta-lactam plus a macrolide. That is standard treatment. But if you do suspect PES, you use piperacillin tazobactam or one of the carbapenems, cefepime, very rarely used these days. And then you may need to use MRSA cover with vancomycin or linezolid as well. And this, of course, needless to emphasize, depends on your local microbiological flora and the organisms prevalent in your community. That will really guide your initial treatment. There has been a lot of focus on macrolides and how effective they may be, particularly in comparison to fluoroquinolones. Macrolides are effective against atypical organisms, and they also, in addition to their antimicrobial effect, they have potent anti-inflammatory effects which might have a positive impact on clinical outcomes. So in addition to the antibacterial effect, they have anti-inflammatory effect, but they may not be particularly beneficial in patients with less severe pneumonia, just hospitalized patients who do not need ICU. But in those patients who need ICU care, macrolides may be advantageous. How does it compare with linezolid? There has been no head-to-head comparison comparing a macrolide a regime including macrolide versus a regime including quinolone. But from indirect evidence, particularly from meta-analysis, there is fairly good evidence to suggest that inclusion of a macrolide in the initial therapy does improve mortality. So that's the Siegel et al. Meta-analysis which came with this finding. So the point I would like to emphasize is, as part of the initial empirical therapy, the use of macrolides would certainly be advantageous. It's been shown to improve clinical outcomes, including mortality. There's a lot of focus these days on the level of respiratory support, particularly with the increasing use of high-flow nasal oxygen and NIV. So in severe community-acquired pneumonia, in patients who are borderline hypoxic in your ICU, would you be okay with offering them just conventional oxygen therapy with nasal prongs or a Hudson mask? Or should you straight away be using other supportive modalities, including high-flow nasal cannula or NIV in comparison to conventional methods? We are all familiar with the Flow Rally study of 6-7 years ago, in which they compared high-flow nasal oxygen with NIV and a conventional oxygen mask in acute hypoxemic respiratory failure. And this study found the primary outcome was to look at the intubation rates. They did not find any difference in the intubation rates between these three modalities of support, but the use of high-flow nasal oxygen was associated with the most ventilator-free days, even compared to NIV use. But there was no difference in the 90-day mortality. The 90-day mortality was lower with high-flow nasal oxygen, although the difference was not really all that significant. So there has been a lot of suggestion that the use of high-flow nasal oxygen may be of benefit in early severe community-acquired pneumonia among patients who need oxygen in your ICUs, rather than go with the conventional methods of oxygenation. How about helmet NIV compared to conventional NIV mask? Particularly during the COVID era, there were a few studies. There are several plausible physiological mechanisms that suggest that a mask NIV might be beneficial. And in this particular study, Bambira et al., they also compared mask NIV versus conventional NIV mask, and they found a lower risk of meeting intubation criteria with mask NIV compared to conventional NIV mask. Corticosteroids have captivated the attention of critical care physicians across many disease processes. Severe sepsis, septic shock, and community-acquired pneumonia has also been the focus of interest with the use of corticosteroids. More than 2 decades ago, Confalinieri et al., they studied just about 40 patients wherein they used corticosteroid and compared it with a placebo group with no corticosteroids. Although it was a very small sample and it was a secondary outcome, they found reduced mortality with corticosteroid use. So from then on, there has been study after study that has asked this question time and again, if steroids would be of benefit. And the two recent studies that we have in this regard that ask this question as to whether corticosteroids are really helpful are the ESCAPE study and the Cape Cod study. The Cape Cod study was published just a few months ago. They studied patients with community-acquired pneumonia. In fact, they began their study well before the COVID pandemic. And as the COVID pandemic spread in this French study, they had to temporarily cease the study, and then after COVID they tried to resume it, but then at that point of time they terminated the study and they analyzed the results. So they use hydrocortisone as a continuous infusion in a dose of 200 milligrams per day and compared it with placebo. And all their findings, as you see here, the 28-day mortality, the 98-day mortality was significantly lower with hydrocortisone use. Intubation by 28 days was also lower with hydrocortisone compared with placebo. The use of vasopressors by day 28 was also lower. So this particular study, it seemed to strongly suggest that hydrocortisone across a heterogeneous group of community-acquired pneumonia could improve clinical outcomes. Of course, one of the problems with the study was they did not use specific diagnostic modalities, including multiplex PCR, which was left to the investigators. So there was no real distinction between viral versus bacterial, whether one group would be more beneficial than the other. So that question remained unanswered. In contrast, in this Meduri study, Meduri, as you know, has been one of the strongest proponents of steroid use, not only in pneumonia, in IRDS, sepsis as well. But in contrast to the Cape Cod trial, this study, which used methylpred as an infusion for a variable period of time, they did not find any difference in the 60-day or 90-day mortality. So these studies were slightly in contrast to each other. So what was the difference between these two studies, and how do we reconcile to the fact that a strong proponent of steroid use could not prove his theory, and on the other hand, the Cape Cod trial showed benefit? The first point to consider is the time of initiation of therapy. The Cape Cod trial, they started steroids much earlier, within the first 24 hours, compared to the ESCAPE trial, which started using steroids later on, after 72 to 96 hours. Methylpred was what Meduri has always used, and he did so in his pneumonia study as well, while Cape Cod used hydrocortisone. The dose of steroids was also different, and that question also remains: what is the optimal dose? We still do not know. The duration of treatment was longer with ESCAPE compared to the Cape Cod trial, 20 days versus 8 to 14 days. Another question we do not have answers to is, would steroids be more beneficial in more severe disease compared to milder disease? And then again, as I mentioned before, viral versus bacterial. Would it be more beneficial in viral is a question that has been often asked. Although the initial studies with viral, particularly during the time of H1N1, very clearly seem to suggest that steroids may be harmful. But then with COVID, with the recovery trial, with the Cape COVID trial, there was plenty of evidence to suggest that early use of steroids might be beneficial in severe viral pneumonias. And of course, there may be subgroups of patients who might benefit. We are still unclear about those patients. The duration of treatment is another contentious topic, but most of the evidence seems to suggest that you do not need to treat your patients for more than 5 to 7 days. 48 hours of clinical stability is what the ATS and the IDSA recommend. Longer duration obviously will be required under specific circumstances like empyema, for instance, or if there is infective endocarditis, or if there is cavitating unresolved pneumonia. But leave alone those resistant infections which might require longer treatment. Generally speaking, 1 week is the limit. Biomarkers, as I mentioned, procalcitonin may be used only to guide you on the duration of treatment and wean off treatment, decide the duration of treatment, not in terms of diagnosis, not in terms of the initiation of treatment. So early identification is important. Multiplex PCR helps identify early. Biomarkers may be relevant, particularly to decide on the duration of treatment. Initial treatment holds the key, and a macrolide regimen may be more efficacious. And it may be wise to start with high flow nasal cannula compared to nasal prong or a Hudson mask in severe community pneumonia. Thank you. Thanks a lot for listening.
Thank you, Dr. Jose, for the lucid presentation. May we have all the speakers on the podium so that we can take question and answers, Doctor?
Thank you all. It's always fortunate to listen all the senior faculty who made these complicated topics so easy that most of the doubts are really clear. But still, if you have a doubt, we have this opportunity that all the senior faculties are here who can clear your doubts. Please feel free to ask. Or any comment if you want to add on.
I had a question for Joe sir. Joe sir? So, how do you use procalcitonin in pneumonia, in your ICU? How often do you check?
We don't use it as a routine. We use it very occasionally. And if you do use it, you need to do serial procalcitonin levels to look at the weights, the direction in which it is going. And if it is coming down, of course, it's a good indication that your patient is indeed responding, and it might help you to guide on the duration of treatment, as I mentioned. Not primarily in terms of diagnosis. We don't use it to diagnose or confirm the diagnosis of infection. It doesn't help that in any way. CRP may also be useful, but the strongest evidence we have, of course, is with procalcitonin, including the PRIA trial. But then, of course, not many studies with CRP. It is an old, age-old investigation, which not many seem to be interested in these days. So it's difficult to tell. But then, if you really need to confirm, need to have an idea of whether your patient is really responding to the treatment or not, procalcitonin may be the way to go.
Thank you, sir.
Any questions from the audience? I got one question for Dr. Suresh. Sir, you have any experience of lung recruitment maneuvers in elective surgical patients? What we have found in our experience is patients who have like epidural surgeries or with bilateral subcostal incisions, at the end of surgery, especially long surgeries, deep tendon work surgeries with pneumoperitoneum, laparoscopic surgeries, lung recruitment maneuver stepwise does help in preventing minimizing postoperative pulmonary complications. Any thoughts or insight on this?
So I think that's where the first recruitment actually started, when they used the nomograms and they found that post-operatively patient had a lot of hypoxemia and a lot of atelectasis, and that is a passive atelectasis, compressive atelectasis. And the best way they found out to treat that is to use a larger tidal volume. So I think that the bariatric surgeries, surgeries done in with the prone position, surgeries done where the inflation of the abdomen is done. I think using a recruitment maneuver with a larger tidal volume, traditionally what was used initially is what is called as sigh breathing, which is one of the 3 methods of recruitment. So sigh breathing is probably the best way of doing it, or a little larger tidal volume in that next few minutes to recruit the alveoli in a passive collapse is an absolutely accepted maneuver in that group of patients.
Thank you.
Question to Ram sir. Sir, your last slide was too simplified to the mechanical power and the esophageal pressure manometer monitoring. You simplified it saying that along with the driving pressure, applied pressures, tidal volume, probably we are talking about a respiratory rate being involved in that mechanical power equation. The other things of compliance and all being never a part of any of our at least the targets. So do you think that now this is a time, if not mechanical power, restricting respiratory rate Because if you see these all ARDS networks guidelines, this push us saying you can go up to 35
Yeah.
and target your pH to 7.25. If it's not, push some bicarb. I think that age-old things are still in the minds of many of our colleagues and students. Is it time at least not to the mechanical power being a target, respiratory rate being a target, but again compromising your minute ventilation and other things. So how do you want it to go about?
Yeah, I completely agree. The lack of focus that we've had on respiratory rate is something that is again brought out in the last paper I showed you about Amato's paper, where he effectively says that the calculation of power is reasonably redundant. That if you focus on two components alone, that is your driving pressure and your respiratory rate, okay, it'll be more than adequate. Remember, they'll grow reciprocally. Very commonly, if you're trying to aim for a normal PCO2, if you raise your respiratory rate, you have to cut your tidal volume, and ultimately your driving pressure will come down. And they say, look at that ratio that you're talking about, that 4 delta P plus respiratory rate as a combination value. And if that value is going upwards, it is associated with a higher mortality. If it is going downwards, it is sometimes better. See, sometimes what you will get is if you make a change in your tidal volume, the driving pressure may come down very marginally, and you need to adjust your respiratory rate may not be very high, very significant. So the net effect of that kind of a change can be beneficial or adverse. So they suggest, and I didn't have the time enough to show you the nice worked out slides that they have of 2 different compliances and how a patient would respond for a reduction in your driving pressure, and how you need to change your respiratory rate, and how that will have an effect on this product. This 4 delta V plus respiratory rate seems to be a very valid way to look at it. So you can't just look at it as high rate or low rate. It is high rate in relation to the reduction in delta pressure that seems to matter. It's a little too complex for me to put into a simple slide, but I strongly recommend. This is a 2021 paper, which I think in the noise of COVID we sort of ignored this paper, but it is absolutely worth reading it. And like the first Amato paper, it will take you another 2 years to understand it. And I promise you, I do not understand it in detail enough that I will look at it a little bit more. But this is fascinating. What they're trying to say is, forget about the power, but the idea of respiratory rate and the fact that, all the shear stresses are very important, makes the respiratory rate a very important thing to control. But how? Varies.
So this is to Joseph, sir. This is regarding, you made a last statement, the steroid may have a role to play in viral pneumonias. So I hope we are getting away with COVID. The recovery trial, COVID, all was a part of one particular syndrome of viruses. But we are not extrapolating it to influenza, because during the whole pandemic of influenza, many trials proven it to be probably a kind of a negative kind of effect or adverse outcomes with the steroid. So what is that reason you find influenza, we could not find the same kind of results which COVID has shown? And do you still recommend, because now we are going through H3N2 as a predominant viral phenotype which has been circulating, and we are getting ICU patient with a sicker pneumonia. Do you think the same kind of phenomenon of steroids use can help them?
I think one of the most striking things that you would find is the older studies, particularly during the H1N1 period and other epidemics that have broken out in between. They were all fairly small studies, sample size is very small. And that is one, of course. And second, the dose of steroids, as to when you commence the steroid, these things do matter, I feel. And one cannot really ignore the recent trials, particularly the recovery trial, which very conclusively showed improved outcomes with dexamethasone in COVID. And then, of course, this Cape Cod trial, I think it's a very strong indicator. 800 patients, that's a fairly large number. No study that comes anywhere near it in terms of sample size. So that also, although they did not distinguish between viral versus bacterial, that question still remains, I feel. But on the whole, the impression that you would get from the more recent trials, especially Cape Cod, is that if you are have a severe patient, severe in the sense, like you mentioned, on ventilation, vasopressor use, there are several minor criteria as well. If they fulfill these criteria, it may be on the balance beneficial to start steroids early rather than wait. And then many of us do that. We wait, we see if they settle down in the first few days, then things go down in a heap, and then you start steroids probably at a very late stage. And that obviously carries poor outcomes. So I think given the evidence we have at this point of time, in severe community-acquired pneumonia, early corticosteroids will probably be helpful, although the answer is not 100% definite even at this point.
Thank you all. We'll continue question answer.
Hi, I'm Dr. Farhan. I'm a pediatric intensivist. I had a question about mechanical power, sir. So, this was a discussion about driving pressure multiplied by 4 into respiratory rate, which you were saying, which is equal to, you may ignore mechanical power, you said, and then you can just use this. So, there was a counter argument to this because mechanical power includes a lot of other things. The Gattin's equation in volume control mode, I'm talking about, not pressure control mode, takes respiratory elastance, takes positive end expiratory pressure also. So we are ignoring that fact because positive end expiratory pressure also is an important aspect of inducing the injury and a contributor to mechanical power. And then, yes, mechanical power, we don't know how to use it even now. It may be just bad setting by the operator, or it can be just a representation of a bad lung, or it can be combination of both.
Yeah, I agree with you. I think, okay, the issue that you're raising about the components of mechanical power that are relevant, again, the same Amato is the last author in this. I don't know why I pick on him as the main author. This paper also says that when you look at the varying components of power, the ones which have the greatest predictive value are what your driving pressure related, not your static pressure, which is your PEEP, nor is it your your resistance that is going to make a difference. It is dominantly the driving pressures that are relevant. And that's what they're implying, that the strongest component is not so much the PEEP. And I raised the concern about why PEEP will not be a good component. It is clearly biphasic in terms of its response. So to include that as a measure of power and to say raising PEEP is going to hurt the power and therefore is going to give an adverse outcome, it will not be associated at all. So clearly what we are recognizing is the two more important components of anything that is of the mechanics that are relevant is going to be the driving pressure and the respiratory rate. And I would strongly recommend, and again, I don't have the width enough to explain that paper, but there are very nice examples in that paper where they work out how the changes in your respiratory rate and the changes in your driving pressures can make a difference in one direction or the other, that the product, that the sum of all of that is probably far more relevant. So I think it is quite important. I think we're just barely understanding power. But one thing, I think we were too simplistic in saying that since power covers all aspects of mechanics, it should be the ideal way in which you need to look at it. It is probably unnecessarily complicated. And I think the delta P and respiratory rate are easily derivable parameters, and we should be probably looking at them a little bit more.
Thank you all. I think because of time constraints, we need to close this question answer session. So we'll